Okay, we'll get started in just a minute or so. If Shane or somebody or Michelle, can you just eyeball whether we're close to quorum or not before we start the meeting? As we're gathering our participants up, we'll be starting shortly. I see our numbers are still rising.
I'm showing we have 7, so one short at the moment.
Okay, let's begin the meeting, and what we'll do is we'll at roll call time, see who's on and make sure we're not voting on anything until we have the necessary quorum. Is that correct, Shane?
That would be correct, which I think includes adoption of the agenda.
Okay, so let me wait just a minute or so more. So what I can do is prior to the adoption, yes, Shane, anything?
Actually, I think we are good if we want to proceed now.
Okay, sounds good. Okay, everyone. This is the Maryland Commission on Public Health. It's my pleasure to call to order this meeting of the Commission on Public Health as established by the legislature and the governor of Maryland. Today is May 20th, 2025, and the time right now is I have 1:02 p.m. My name is Boris Lishniak. Today I serve as the presiding chair. Also, I think I have on both my co-chairs, Dr. Oluwatosin Olatehu and Dr. Meenakshi Brewster. Um, I'm just going to sort of go through just briefly, as I tend to do whenever I'm chairing, just to remind you that the Commission on Public Health was established in 2023 to study and make recommendations to improve Maryland's public health system. Um, the 16-member body, which is now down to 15 members, is comprised of local health officers, academic partners, thought leaders, and legislators. The Maryland Department of Health is represented by the Deputy Secretary for Public Health Services, the Deputy Secretary for Behavioral Health, and the Director of the Office of Minority Health and Health Disparities. Many additional leaders and professionals are contributing to the Commission's 5 work groups, which includes um, funding, governance, and organizational capabilities, workforce, data and information technology, and communication and public engagement. And our goal is to ensure that the public health system is designed to help all Marylanders achieve their best health and a lifetime of wellness. Our meetings are held monthly and streamed online. Today is a special meeting, which I'll explain shortly. Uh, this is a public meeting. We have followed the requirements of posting a notification of this meeting. This meeting is being video recorded. By your continued participation in this meeting, you consent to the video recording. We ask members of the public who may be attending to mute their microphone during this session. This meeting does not, I'll repeat, does not include a time period for public comments. We'll not be monitoring the chat function during the meeting. We encourage public comments to be sent via email to md.coph@maryland.gov, md.coph@maryland.gov. We also ask members of the commission, the commissioners themselves, to mute your microphones when not speaking. Please use the raise hand function to indicate that you wish to speak, and you will be recognized. Individuals who serve on the commission are subject to Maryland public ethics laws. All have confirmed their agreement to this in their applications and listed any conflicts of interest. I'll now ask Shane to conduct a roll call of the commissioners. Shane, please. You're on mute, Shane.
Apologies. When I started sharing, I lost my controls.
Oh, no problem.
When I call your name, please respond with here or present. Delegate Heather Bagnall. Camille Blakefall.
Here.
Mr. Christopher Brandt. Mina Brewster.
Here.
Jean Drummond. Senator Clarence Lamb. Matt Levy.
Here.
Deputy Secretary Alyssa Lord. Boris Lushniak.
Here.
Deputy Secretary Nilesh Kalyanaraman.
Here.
Oluwatosin Olateju.
Present.
Maura Rossman.
Present.
Nicole Rochester.
Present.
Michelle Spencer.
Present.
Alan Twigg. We have a quorum.
Great. Thank you so much. And thank you all for your attendance here today. The agenda for today's meeting has been posted and distributed to the commissioners. Any comments from the commissioners on today's agenda? Seeing that there are no comments, I now ask for a motion to approve today's agenda.
I make a motion.
Thank you.
Second, Olateju.
Thank you. All those in favor of adopting the agenda, please say aye or raise your hands.
Aye.
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 Any nays for the agenda? Any abstentions? So we do adopt the agenda. The minutes from the previous meeting, which was held on May 1st, 2025, were posted and distributed. Any comments on the minutes from the May 1st meeting? If there are none, I ask for a motion to approve the minutes from May 1st.
So moved. Second.
Thank you. Please signify your voice vote by saying aye if you approve the minutes from the May 1st meeting.
Aye.
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 Any nays? Any abstentions? Great. So we do have both the agenda approved as well as the minutes from the previous agenda also approved. I'll ask Shane now to provide to us any updates regarding the Commission on Public Health and where we're at in our whole process. Shane, if you will.
Thank you. I won't take very long here, except to remind folks that we will be reviewing and discussing our full slate at the June 5th meeting, which after that point, we hope to take the slate to the open comment period as required by statute. That is partially what is driving this timeline and our cadence of this work. Again, a brief reminder, which we will put on your calendars here soon, that we made the September 11th meeting virtual and as needed but we will be meeting in person and holding our final meeting on September 25th of this year, at which point we plan to adopt the final report prior to the October 1st deadline. That's essentially where we are in terms of our timeline overall. Of course, this was the last meeting prior to that June 5th slate review. And so we do have quite a few recommendation submissions to review from the work groups, with a very truncated time period for them to make any modifications if they are requested from this meeting. So you'll notice when we go to the polling portion that I've put a note in the recommit to work group option that work groups at this point may not have time to sufficiently address any concerns the Commission expresses prior to that June 5th meeting. If there are no questions, I'm happy to transition us to the submissions process.
Any questions for Shane on the Commission on Public Health updates that he just provided? And again, I do want to stress, though, as we look at these, and we have a whole slew of recommendations to go through today, so we're going to try to make sure that we are as efficient as possible. This is one of our additional monthly meetings that was added to the schedule for that specific purpose, which is looking at the submissions prior to our June 5th meeting, where we'll have the opportunity to look at the whole slate one more time before it goes off for public comment. I also want to emphasize the fact that the issues of voting for are quite obvious. That means that it goes to the June 5th slate. The voting against means that you do not support that submission. Abstaining means that there's a variety of reasons why people sort of have either said, I don't have enough information, or so. We'd really, in this case, do want to know that abstentions should be noted in the chat and raising your hand at the time, just so we can see sort of the delineation of abstentions. So as mentioned here, and you can see in our slide right now, so advance to the slate means submission is approved to be considered for the June 5th recommendation date. We can do minor tweaks, or items can still be addressed, but largely that they're good to go. Recommit to the group, as mentioned here, that the submission could be supported but needs more refinement work. Once again, we're running under timeline, but I think, it should not stop us, right? And we just have to go into consideration that the work groups may or may not. We'll try to push through with our work group chairs. Many of them are on to hopefully look at how quickly things can be fixed up so that they'll be ready for June 5th submission. And then the voting nay cannot support that the submission does not have the broad support of the commissioners to be included. And as mentioned with abstentions, we'll be asking for raising your hand and noting that in the chat as well. So that's going to be our process from right now on. And this is those, I know all the commissioners have at least been on several of our meetings that have been taking place. The cadence sort of quickly develops. We do want to have discussion where discussion is necessary. We have many of our work group chairs here. And I do want to give a shout out in particular to our work group in general, but the work group leadership in particular for the incredible amount of work they've put in here, right? I mean, these recommendations that you can see are really sort of cross-cutting in terms of what the work groups have taken on in terms of their own specific tasking. There's certain areas. We also have a few recommendations today that came from the assessment team that was cross-cutting work that we've also included in the recommendations that are going forward. So today it's going to be, at this point, a movement. We have 1 hour and 45 minutes, and so let's get to work. So Shane, let's begin with the introduction of submissions. Last time we found it fruitful to first have a reading of all submissions by the work group, then introducing the discussion individually with individual votes. The voting is going to take place online. You should have received a mailing shortly before this meeting with a QR code that gets you in to a site once you follow the directions. The directions included a specific password, a password and a name. That then gets you into a component of the app where I'm at right now, which basically says it's COPH May 20th, 2025. The session is due to start at 1300 hours, waiting for the host to start. So when we get to our first voting, Shane or others will be pressing special buttons and getting us into our voting for each of the entities that are out there. So Shane, let's begin with the reading of the recommendations in small batches, so we can do a once over.
Okay. The first that we have is DIT 046 System Modernization. This is to establish a public-private system modernization standing commission to streamline and centralize decision-making process for new needs and evolving technologies, including things like artificial intelligence, and to improve efficiency, support, flexibility, and ensure security and effectiveness. The next submission from the work group is DIT 047. IT and Analytics Workforce. This recommendation is to invest in a state public health IT workforce by supporting academic centers in training current and future workforce in information technology and information services and analytics. Incentivize retention through loan forgiveness, in-state tuition, and following commitment to public sector employment. Use the savings from consolidation of electronic systems to translate into more competitive hiring practices. Encourage a hybrid IT workforce that places individuals at the point of maximal effectiveness. Next is DIT 048, Record Digitalization. Digitize all public health records into redundant, secure, and accessible systems. Reduce paper use and waste by 90%, which will have a significant effect on cost of products and space. Next is DIT 049 Business Systems. Health department business functions should be achieved with the least number of systems to create consistency across local health departments, cross-jurisdictional business activities, including but not limited to budget, finance, accounts receivable, human resources, procurement, medical billing, and grants management that require collaboration should strongly consider implementing the same system to minimize redundancies, maximize revenue capture, and streamline processes. Next is DIT 050, and that is for environmental health systems. While ideally incorporated into the universal electronic health record system previously discussed, environmental health poses unique challenges, including permit capture and online payments, public input and tracking of licensure, complaints, investigations, and other unique functions. Local health departments, Maryland Department of Health, and Maryland Department of Environment should identify and purchase one system to use throughout the state. Next is DIT 051 Enterprise Architecture. Design and implement a local and state 5-year enterprise architecture plan to ensure a roadmap for implementation. This will improve funding predictability as well as system awareness and constituent buy-in. This plan should build in flexibility and checkpoints to pivot to market and technology changes. Next is DIT 052, Core Funding for Technology. The recommendation is to create a separate technology core funding line item that supports the current and emerging technology needs of state and local health departments. The final submission from the work group is DIT 053, Create a Central Community Portal. The recommendation is to create a central community portal to include both data collection function as well as interactive, downloadable dashboard and tools for community engagement and education with a focus on Maryland-specific data sets.
Great. And thank you to the DIT working group. And I think at least one of the co-chairs, Matt, I believe we have co-chair representation there. So let's move back. That was sort of an overview of the recommendations coming from that working group. Let's go one by one. The process now is any comments or questions about the specific recommendation, and then we go to vote as to whether it goes to the slate. And yes, Mina, you have a question?
No, actually just a comment on the first recommendation. That's all.
Okay, great. So let's begin with the first recommendation. Mina?
So this first one, what I would recommend doing is adding the words public health in front of system modernization, just to clarify that we're not talking about all of state government and so forth. We're really focusing in on the public health governmental system.
Other recommendations, comments? From the working group, Matt, you're a co-lead on this. Is that correct, Matt Levy?
Yes. Do you want me to
any-
make do you want me to make a comment, or do you want me to just let it?
No, I just went. No, not a comment. Any issues with Mina's recommendation from the work group perspective?
No, not at all. No, I think that's a great idea.
Okay, great. Any other comments? And if staff members can also help me to sort of monitor if we see any hands raised. I'm sort of going through my list right now. I don't see any. So let's put this up for vote for moving it onto the slate. You should now have that app on. And is anybody having, since this is our first vote, is anybody having any issues? So I have it on my phone. I'm at DIT 046 and at the voting aspect of it. Anybody having access issues from the commissioners?
Is there a QR code?
Yeah, there was one sent in an email in the last half hour, I believe.
Matt, if you look at the attachments about instructions for poll, it'll have all that on there. You can just hyperlink to the link as well.
Let us know when you're on, Matt. Or if we can assist you in any way. All other commissioners, are you on already?
Yes.
Okay.
Thank you.
This is Camille. I am looking for that email from 30 minutes ago. I can't find it. I do see a couple from Shane, but I don't know if it's embedded in one of those.
It would have been an attachment in, there was one rather long one with multiple attachments. If you go to the first attachment, at least it was at the bottom of my email.
Yep, got it.
First attachment, click on that QR code comes up. Matt, have a look at that as well. Okay. So we have all commissioners, any commissioner who is not in as yet. Again, we're going to just take a little while longer here to make sure that we do have everybody pressing the requisite buttons.
We are at 7 votes cast so far.
Okay, we end. Matt, you in? The vote.
I only have one person who hasn't cast a ballot. Are they clear concern? 10. Okay.
Are we good, Shane?
Oh, yes. Sorry, I meant there. This
Okay.
will advance to the June slate.
Okay. Great. Let's go to our next one, which is DIT 047, the IT and Analytics Workforce. Open for discussion, comment. Anything from the group?
I'm sorry, I cannot figure out how to raise my hand.
Okay. Yes, please speak.
Just had a question on hybrid IT workforce. Could you talk a little bit about what that refers to?
Yes, it's really more, maybe that's not the best wording, but it's about being flexible with the workforce, because there's a lot of now folks that work both at home and in a facility. They work either at the state level or the county level, and to be flexible in where they work so that we can maximize the workforce's interest and willingness to participate. Because if you move everybody on site, then you potentially lose a lot of people that might want to work a hybrid relationship. So I think that's all we were talking about. It is probably poorly worded. And the maximal effectiveness is if they are working at the state level, then they should, and they need to do something but if they're like put out into the county to work in partnership, they should be able to go to the county, not just be at the state level. So I don't think maybe we worded that correctly. Sarah, did you want to add anything to that?
No, I don't think so. I think, as you said, we can add some clarity in that language to talk about how it, as you said, for maximal effectiveness. I think just to recognize that not all areas maybe would have the IT and analytic workforce there on site, but to maximize their impact across the state.
We can change the wording on that.
Any recommended wording that you would put in at this point?
I have a recommendation.
Yes, go on.
Maybe encourage. Go ahead, Nina.
Oh, no, go ahead. That's fine. Go for it.
No, I'm having trouble.
How about just support hybrid work options for the public health IT workforce in order to maintain, or in order to maximally recruit and retain the workforce.
And I'm assuming. So is this coming, are the current classifications for this, are they restricted to on-site only? Is that kind of where some of that part is coming from? Are there restrictions?
Well, it's going to depend because some jurisdictions utilize their county HR policies and so forth. Some utilize the state personnel system. So it's really a mix of that. So I think this recommendation would apply towards both the state personnel system as well as the county personnel systems that are utilized for public health IT. Sounds like it, individuals.
That I think would be important to add or clarify.
Okay.
Any recommendation? Was that you, Camille?
No, I have nothing to add.
Okay.
This is Tosin. I just wanted to say if we could maybe keep the recommended language short. I really like Mina's suggestion. And then the remaining pieces of it, loan forgiveness, institution, those can go under, you can create a sub-tab under it, action steps, to implement that. That way the recommendation language itself is very, very clear on, in terms of the focus. Thanks.
Great. Any other comments? And again, I'm going to stress enough that, it is, to a large extent, what we're trying to do is make sure we get in the right wording here. Don't forget that this is going to the public comment period, in which case we still have the ability, obviously, to listen to the public, and public does include us as commissioners, refine this further. Really what we're doing in terms of the slate is, in essence, is this a recommendation that will we be supportive of? Any other comments? Okay. Shall we go to vote of this recommendation? And again, QR code. The vote has now come up on my phone. We'll have Shane monitor once we get to the right numbers.
Waiting on 2 votes. 1 vote.
Anybody having issues voting? Okay. Okay.
Advance to the June slate.
Okay, great. Thank you. Let's go to DIT 048, which is record digitalization. Comments is open.
I don't see any hands.
Okay. If no comment on this, let's go to vote.
Waiting for 1 more. We're missing a vote, but overwhelmingly, okay, there it is. Advance to June slate.
Great. Thank you so much. Next vote from the DIT working group is 049 in business systems. Comments are open to this recommendation.
I'm not seeing any hands.
No hands. Okay, let's go to vote on this recommendation. Should be coming up on your devices. 049 business systems.
Missing 2 votes. And this will advance to the slate.
Okay, moving ahead to 050 environmental health systems. Any comment?
Mina has her hand up.
Yes, thank you. I do have a concern about this one. While I think the ideal of it is strong and good. I think it's, we also have to consider that some LHDs are already doing EHR integration with their local county governments when it comes to environmental health records and permitting and perhaps even fee collection. So I realize that this recommendation includes LHDs, and that acronym should probably be corrected to LHD, not LDH. But at the legislative sessions in previous years. If we consider the systems that local county governments already have in place as well.
But it doesn't work well. And having a single system that integrates with the EMR system would be probably equally as effective or more effective in the process, because then you have a stream collecting both the clinical data and the environmental data, and you're using a system that also allows for permitting and tracking and disease tracking and licensing and all that stuff. So
yeah,
whether it can be built or not is the question, and whether county governments will support that is
I'm not disagreeing with the concept. I think the concept is strong, right? It certainly makes it easier on not just the agency team members, but also on the public who have a go-to space and so forth. The challenge really, though, I think is, it may not be working as well in one particular county, but some of the processes at the county level are set up in a system that involves points of intersect. And so removing us, for example, in St. Mary's from the equation would really disrupt some of those processes that our local county government utilizes that are related to land development, for example. So I'm just saying that if we do proceed forward with this, we really need to ensure that there's input from those county governments in addition to LHDs, MDH, and MDE.
So you would recommend that we change LDH to LHDs, and we add in county government or local government, MDH, MDE should identify. So they should have input into the conversation. Mina?
Yes, if everybody wants to proceed forward with this, I would recommend the input be broader.
Yep.
It looks like we have a couple other hands up, though, with comments.
Vanessa, I see your hand up.
I'm just reading through this again, noting and hearing what Matt is saying about the importance of interoperability. Should the recommendation have a stronger focus on interoperability, with aligning with one system being a potential way to achieve interoperability, but leaving maybe a little bit of wiggle room for implementation?
To clarify, Vanessa, are you saying, which I would agree with, if it's saying identify and purchase one system to use. So it's not just one system to use. It might just be one. It might be a system that involves interoperability of other existing systems.
I think we have interoperability in separate recommendations. This one is intended to, especially for smaller counties, the thought here is that there could be a lot of savings and improvement in integration and interoperability if there were fewer systems. So, this isn't intended to be consolidation, save money, save labor resources that are required to maintain myriad systems across the state, and improve bargaining power with suppliers. And I realize that this is difficult to execute because of the different stakeholders involved, but it's trying to push us in a direction towards, towards a little bit of consolidation.
Yeah, I think it is complex, as you mentioned, Chris, but I think the whole idea that, I think what the working group has done is obviously identified a problem, and it may not be full resolution of the problem through these words here, but it sort of does profile this problem in terms of building in more efficiency. So I see your point on that. Any other comments? Go on.
Would it make sense to put in something like, while ideally incorporated into universal EHR? So let's see, creating an interoperable environmental health program or environmental health. I'm trying to see where it would fit in. Maybe you put local governments, including LHDs, MDH, MDE, should identify purchase one system that can that functions with interoperability to use throughout the state or something like that. So, or one interoperable system to use throughout the state. That way that incorporates what Vanessa was mentioning and what Mina was mentioning, where we don't know what it's going to look like, but we want to have kind of ideally one system that works with other systems if it's not inside of the EHR system to begin with. Chances are that it's not going to be, because EHR systems are not designed that way, but there might be an interoperability where some data is collected in one place and another, but they share common language, so you can pull data from either back and forth.
Any other comments on this? And do we have, I guess, the question is, are we able to do the requisite modification here, or is this something that needs to go back to the work group? And any recommendation? Matt, you're part of the co-chair, so the question is, and Chris, you're part of that working group as well, correct, Chris? Is there anything that we can do here as a commission to make this evident of what we're voting on?
We need to adopt it and then modify it or we modify it and adopt it from the Robert's Rules of Orders.
Okay, I think we get a gist of what you're saying. The question is, as we're putting this up to a vote, which is our next stage, are we ready to go for a vote with the conclusion of this comment, and that there will be further modifications, I guess, or are we ready to go with any modifiers right now? I just want to make sure that we as a commission understand what we're voting on. Somebody was speaking?
Yeah, Boris, sorry, it's Shane. Yeah. If I could interject, just a reminder that what we're adopting today is not necessarily in final form. And as we've said all along, that there would be continued refinement of the language, that essentially what we're voting on today for the most part, and what we have been voting on, are the core concepts and underlying substance of these recommendations. And so what we bring forth on June 5th really will represent more of that final stage product that goes out for open comment. So based on the discussion we've heard here, assuming that Matt, as co-chair of that work group, is able to interact with us for some additional discussion, I don't think it would be impossible for us to address the issues we've heard. But that said, if there is heartache about this, we do have the ability to still address this through areas of future inquiry in the final report, as well as, again, that open comment period where others outside of the commission would have ability to engage.
Okay. So let's close discussion at this point and go to a vote on DIT 049 or 050 environmental health systems.
Just to
Yeah.
clarify that on the DIT 050, did we change this language to be LHDs, MDH, MDE, and local governments?
Yes.
Or are we keeping it, are we voting on what we see on the screen in front of us?
Now, I think we were discussing adding the local governments into that.
And correcting the LDH.
Okay. Yes.
Great, thanks.
Okay. DIT 050 is up for vote.
I'm waiting for one vote. And this will advance to the June slate.
Okay. Let's go to 051, enterprise architecture. We're open for discussion. Any points of discussion here?
Again, for this one, again, it may be helpful to clarify that we're talking about public health. Or are we talking about, I mean, we're not, I'm assuming, addressing all of Maryland.
Yeah. So modified to be specific for public health. Any other comments? Okay, let's move through on the vote on this one. 051. Jane, are you pressing the buttons here?
I'm sorry.
Oh, sorry. Okay. I
Oh,
think you.
Nicole? Oh,
No, I was just going to say I don't see it, but I think you've already addressed that.
Yeah, I'm waiting for it myself here. Hold on one second.
All right, there you guys go. Sorry.
Okay, should be up now. Okay, where are we
We're
at?
seeing
Shane?
one vote.
Okay.
All right, we have all 10 advanced to the June slate.
Okay, let's move to 052, which is the core funding for technology. Any comments?
So this one, I just wanted to clarify, I was a little confused by the language because it emphasizes the word core. So is this saying that there would be a specific line item under the existing local public health core fund stream? Or are we saying that we're designating an additional funding stream specifically for public health technology?
The idea behind this is that there will be additional funding for a separate, stable source of money to support the technology infrastructure and development of technology across the state and local.
Then,
so it wouldn't be under core, our current core. It would be under be a new source.
I would recommend removing the word core then, because it causes confusion, and it might be interpreted to be that a portion of core funds would need to be dedicated or allocated towards a technology purpose.
Would it be, would we want to then, I'm fine with that. I think we need to make clear here that this is ongoing funding.
Sure. So if you just say create a recurrent technology funding stream or technology, public health technology, I should say, something like that. I just wouldn't use the word core because it causes, I mean, like me, I mean, I read that to be, oh, you're talking about the existing core fund, not a new funding stream.
So dropping the word core, just call it create a separate technology funding line item.
And you may want to clarify in the state budget.
Mm-hmm.
And adding in public health in front of technology.
Would we put ongoing in there somewhere?
Sure. If you say recurrent, that might,
recurrent.
you know, I mean, that might suggest you're talking about a operating budget expense, or you could say ongoing or whatever the words might be.
Okay, with those modifications, any other comments? There are none. Let's put up 052 up for a vote.
Vanessa had a.
Oh, Vanessa. I'm sorry, Vanessa, go on.
Sorry, I'm slow to find
no problem.
Raised hand. So I think would this be, so I know for several of the local health departments that are under MDH OET under Do It, they receive, you know, funding in kind, equipment, personnel, right? So would this be something additional to that, or is this for the folks who are not under MDH Do It? I'm just trying to wrap my head around the recommendation.
I would think it would be in addition. Well, in addition, but if that's a source of funding and that's a regular source of funding, then do we expand that and make it available for all the health departments that are, including the ones that are not underneath it? Because then that was the point. It was just to create a stable source of funding where that we didn't get into the details of where that is coming from or how it, you know, it was something that we meant to have available to everybody. So right now there isn't funding available to everybody as far as I know. And nobody on the committee knew that there was a stable source of funding for everybody. So there isn't a stable source for everybody if there is some funding on a regular basis, Vanessa?
Only for the local health departments under MDH's OET umbrella, right? Who use and I'm not sure we would characterize that as stable, right? Like, I think we know that there could potentially be some volatility. Just trying to connect the current state of things with what we're recommending.
I think the idea of this is that technology is changing so rapidly, and that it's very expensive especially so if there's not a regular source to address those changes and adaptations, then we're going to get behind in what we do. And that was the purpose of this. Mina?
Nina, you have your hand raised.
Yeah, thank you. So just to add to this, even if in the current arrangement, right, and that assumes that the current arrangement continues, which that can always change. And I think these recommendations should exist beyond administrations, really. But in the current arrangement, yes, there are some local health departments that rely upon the state health department personnel support and perhaps now even software, although, you know, for a large portion of the time of that arrangement, it's been the local health departments paying for it out of their budgets. Even in that situation, there's not, you know, the state paying for electronic health record systems, the state paying for, you know, ways to apply AI and so forth at this point in time. So I do think it's worthwhile to designate a separate public health technology funding stream that is both recurring and allows for carryover between fiscal years, just because of the costs of some of these technology items may necessitate accumulating a couple years of funds. And I think that that should be in addition to us looking at our existing operational budgets at the state and local levels and determining which portions of those existing operational budgets go towards technology, either through technology staffing or through, for example, our subscriptions to EHRs.
Other discussions, comments on this? Let's put it up for vote in terms of where this is heading.
This will advance to the June slate.
And we'll take all the comments into consideration as we sort of discuss this further. Thank you. Our last one from the DIT work group is DIT 053, Central Community Portal. We're open for discussion.
Dr. Rossman has her hand up.
Okay.
Yeah. I just request clarification. Where does the portal sit at MDH?
Yeah, it would sit on MDH's platform. So we should probably put that in there.
And how is this different than the current dashboards that exist?
I was going to ask the same. Yeah.
I think the dashboards, so I think this enhances it actually. And also there's a lot of dashboards, but they're not necessarily all centrally in the one spot. The other thing that this allows is potentially for data collection from the community. If we have a survey or things like that, it would allow people to input information. But this is also not just about, it's other tools for community engagement and education. So around the data set. So I think it's just creating more of a central repository and a central portal for people to interact with.
That's great. Did the work group in their research find a model?
We did not.
I'm not aware of something like that for a whole state, so I'm just curious.
We did not.
Okay, thank you.
Other comments? Okay, let's move forward for a vote on 053.
One comment. This was in one of our other recommendations that we pulled it out because we thought it would to emphasize it a little more clearly. So it was sort of a last add-on and the last conversation that we had as a committee.
Okay, thanks, Matt.
Just to add to, what Maura said, I would feel more comfortable with maybe enhance the current dashboard rather than create, so it's not duplicative. Thanks.
Great, thank you, Tosin. Okay, let's bring you up for a vote. DIT 053.
And I'm fine with that, Tosin.
Thanks.
Yeah, I mean, just to clarify though, we have multiple dashboards. We don't have just one dashboard. So
correct. The idea is that you can go one place and get the different dashboards.
Exactly, right.
And sorry, I was referring to the MDH interactive dashboards, just to be clear. Thanks.
Okay, vote is open.
We are good here. And this one will advance to the June slate as well.
Okay. Good. Let's do our next grouping. Shane.
Yep. So the next one is, sorry, let me find my place.
What?
FND 054, revisit core funding formula. This is the only submission from the funding work group, but the language is to review and assess the adequacy of funding models, including the core funding formula for local health departments to execute their responsibilities to address foundational public health areas.
Okay. This is open for discussion. Mina?
I think a recommendation like this should specify who would be doing the review and assessment and who would be involved in that review and assessment. So are we instituting a task force, a commission, or working group, whatever it is, and who would be the representatives in that entity?
So if this is Larry Polsky, if I can clarify, this recommendation did not come out of our work group. This came out of the assessment team. Our funding work group did put considerable time into discussing core funding and could not come up with a consensus plan.
Thank you, Larry. Amelia, are you here from the assessment team?
Yes. I think that it's complicated because it is sort of cross-cutting in a way, because it deals with how that funding formula might be used in a more effective way. So I'll leave it up to you to mince the language, I guess.
So, Vanessa, your hand's raised or not? Yeah.
Yeah, I thought Mina's comments were really good, right? Like, who's going to do the review? And if we don't specify that, it seems like it would be the core funding formula review that I believe we just had as part of the previous legislative session. I'm not entirely sure, but I think there was a joint chairman's report or something to that effect, revisiting the core funding formula and the funding to local health departments in particular over the last couple of years, right? And so if we don't specify that, I think there's an opportunity, there's a possibility, there's some risk in us pursuing this. And we just have to be comfortable with the fact that revisiting a formula could go many of different directions. We could have the same level of funding to local health departments, and there could be a redistribution of those funds among the local health departments, right? That way that we distribute that amount of money may be different. There's also a possibility the amount of money could go up, and there's a possibility the amount of money could go down. So just want to make sure that if we pursue this, we go into it, eyes wide open, that we can't control the outcome.
Thanks a lot for that, Vanessa. I think that there were several points in our assessment where people said if we could only go back to the recommendations of an earlier commission or work group and look at that. So maybe that's a starting point for this. And I'm not even sure if it requires a formal recommendation, but more of a commitment to do that sort of re-examination of something that's already been done.
Mina, is your hand still up?
Yes, thanks. And I was just wondering, and maybe Larry could chime in, because he did mention that there wasn't consensus in the funding work group on a singular recommendation around the core funding formula. however, this is more of a study recommendation versus this is how we would change it recommendation. So Larry, do you think this language is more in keeping? Obviously, if we specify the who and the, who's involved and the entity, is this language more in keeping with what the funding work group would support?
I would say I can't give a yes to that. The recommendation that that you're considering right now is extremely vague. I think the consideration of our work group was that ultimately the two biggest stakeholders in this are local health departments and MDH, and opening a potentially completely revised format up to other parties potentially could have a negative outcome for local health departments and MDH. So I know I'm not a commissioner. I would be hesitant to vote for something as vague as what was put down.
Okay, any other comments? Okay, let's go for a vote on.
This one will be recommitted to the work group with hopes that they will be able to address it prior to the June 5th meeting.
Okay, thank you. Next one, we have a grouping now or not, Shane?
We do. We have the governance and organizational capabilities work group, and bear with me as I jump across PDFs here.
Okay.
Okay. The first is GOC 027, collaborating with social services, housing, and aging sectors. Maryland Department of Health and local health departments will examine barriers and facilitators to multi-sector partnerships at the state, regional, and local level to include problem-solving teams, no wrong door initiatives, assessment of policies and practices for health impacts, and shared data systems to better understand the needs of vulnerable populations, identifying service gaps, and coordinate responses. GOC 028, cross-sector collaboration and communication. Despite the similar title, it is different. This recommendation is that the Maryland Department of Health, in partnership with local health departments, will develop an onboarding education for newly elected state and local public officials about public health and responsibilities, including the duties of local boards of health. So that's a duplicate there. GOC 029, leveraging private health system resources. Maryland Department of Health will identify barriers and facilitators of state, regional, and local health department engagement with private sector health systems through partnerships, joint funding opportunities, research, communication, and coordination. Additionally, MDH will review statutory, regulatory, and administrative barriers to establishing ethical and equitable public-private partnerships for funding to and from MDH and local health departments with the private sector. GOC 052, continued support and enhancement for shared governance in Maryland public health. The Commission affirms its support for shared governance of the public health system that empowers state and local health officials to collaborate and function interdependently to help Marylanders achieve their optimal health and wellness. This model recognizes the role of the state in coordinating and promoting macro strategies across jurisdictions, while vesting authority and autonomy with local health officers to function as chief health strategists within their communities. It further reinforces the principle that each partner is operating with the best interests of their constituents in mind. We support the following steps to strengthen and enhance shared governance. Inclusion of partner agencies that intersect with public health in the shared governance structure, such as the Maryland Department of Environment. Promoting health equity through the public health and clinical health systems through community engagement and representation on local boards of health. Modifying the core funding formula to account for the complexities experienced by jurisdictions that are not accounted for in a flat per capita model. And ensuring public health is appropriately engaged in planning and implementation of significant programs, similar to the approach taken in the implementation strategy of a HEAD model. GOC 042 Public Health Resource Team. The recommendation is to hire 10 to 12 staff level positions at the Maryland Department of Health who are responsible for executing the Commission on Public Health's recommendations and other related recommendations, and to also who can broker the partnerships with public and private entities to leverage their expertise in developing solutions. This panel of experts or strike team can assist local health departments and the Maryland Department of Health with emerging public health issues, public health crises, or policy development. These individuals would be primarily responsible for implementing the recommendations of the Maryland Commission on Public Health and monitoring the success of changes made to the system as a result. Moreover, they could be instrumental in designing and implementing large cross-cutting public health initiatives by leveraging multiple governmental state agencies and external partners. GOC 043, Maryland Department of Health Public Health Grand Round Series. The recommendation is to develop a forum for horizontal communication across Maryland Department of Health departments that would allow sharing of successes of public health initiatives and successes in implementation. A Grand Round series could provide a way to come together regularly around an important topic of shared interest. Local health departments could participate as well as audience members or presenters. Community partners, the public, and legislators could be invited to the Grand Rounds presentations. GOC 044, listserv for local health departments. Establish and maintain a listserv for the local health departments to facilitate communication between them and to share resources and announcements.
Great. I just want to clarify, Shane, I saw on our prep sheet there was a 026. I'm not sure if you went through that. Is that still on the slate?
It is. I had to switch my PDF to get there. GOC 026, Development and Support of Academic Health Department Partnerships. Maryland Department of Health, local health departments, and academic institutions should work towards implementing academic health department models at state and local levels that involve formal agreements with academic institutions in the state, including historically Black colleges and universities, in order to enhance the organizational capabilities of governmental public health systems. This effort may involve establishing an academic health department community of practice in Maryland to develop template memoranda of understanding, suggested actions that academic institutions can take to meaningfully engage with public health departments, and defining standards for a well-functioning academic health department model in Maryland.
Great, thank you, Shane. Okay, let's go back to the
Sorry,
one.
we still have two more.
Oh, two more. Sorry. Oh yeah, never mind.
This was the jumping around part.
Yeah.
GOC 061, establishing a racial equity impact assessment policy for General Assembly. Or I apologize, this is 062, establishing a racial equity impact assessment policy for the General Assembly. The language from the recommendation is establish and operationalize in the Maryland General Assembly a racial equity impact assessment policy to ensure racial and health equity are central to the development, implementation, and evaluation of proposed legislation. And GOC 061 is establishing a statewide racial equity impact assessment policy for the executive branch. The language is establishing and operationalize in state government a racial equity impact assessment policy to ensure racial and health equity are central to the development, implementation, and evaluation of the promulgation and removal of regulations by social determinants of health-related agencies to be defined by the Secretary of the Maryland Department of Health when circumstances or thresholds determined by those agencies are met. And that concludes the submissions by the Governance and Organizational Capabilities Work Group.
Great. I'd like to congratulate that group for their excellent work as well. And let's begin one by one and looking at discussions. So first one up is
GOC 027.
027. Collaborating with social, service, housing, and aging sectors. Any comments?
I don't see any hands.
Okay, no hands raised. Let's go to a vote on this one.
I have my hand raised. It's just more of a typo. In the second box, I think it's missing T for D. That's all. Just, yeah. The health of individuals.
Thank you, Tosin.
You're welcome.
Okay. The vote should be up.
Okay, at 9 votes, this will advance to the June slate.
Great, thank you. Next vote, I think, is on 028. Is that correct?
Yes.
Okay, that's cross-sector collaboration and communication. Any comments?
I do not see any hands raised.
Okay, thank you. Let's go to a vote on 028.
Missing 1 vote. There we go. This will advance to the June slate.
Okay. Let's jump to 029. Leveraging private health system resources. Any comments?
Dr. Brewster has her hand up.
I think we need to insert local health departments in this, in the spirit of being tuned into local barriers and process.
This is Chris. Is this the appropriate place to insert? I do worry when we killed the one last time on the community benefit dollars with hospitals to encourage a sentence here to push for transparency on hospital community health benefit spending.
Sorry, Chris, just to clarify, are you saying that we need to add that language in to this
Yeah,
recommendation?
I'm suggesting I mean, it's short of the provider tax, it's well short of the provider tax that the finance committee had asked for, but I do think that there's merit to making the hospitals more accountable and like to public health outcomes. And so the thought, this seemed like a place where maybe we could add that sentence as like a formal recommendation that is, strengthening that tie of accountability. And I think it's just one sentence to push for transparency for each hospital in terms of how the community health dollars are spent on a quarterly or annual basis.
I will note that Dr. Brookmeyer from the work group is on if we wanted to ask for her thoughts on that.
Dr. Brookmeyer, any the points from your working group's perspective?
Well, I think that the way it is written, it could potentially have touched upon the hospital community benefits and speaking about, the legal parameters around which the state has any role to potentially exercise, any authority to potentially exercise regarding how community benefits are spent or invested, how community benefits are invested and invested by whom. But I don't think that is not the gist of what I understand your question to be about, which is actually about the community benefits and about where they are invested, by whom they're investing, and what principles those investments must align with. And so from the work group, I would say one, if the commission wants to add something, I think it's the commission's prerogative. And then whether that's coming from another work group, I would say that we would be friendly to other work groups identifying an opportunity for cross-cutting interests to be included in one of our recommendations.
So I know Tosin has her hand up. Chris, if you can sort of work out this idea, do you have a sentence that you would like to add to make it more clear or not? Tosin, to you.
Yeah, given that it's looking at, leveraging private health systems resources, my thought is the HSCRC would be a good, partner for this initiative, and also the Maryland Healthcare Commission, right? So I don't know if there's a way to maybe have that engagement through this recommendation. I think it would be really, really worth it.
Yeah, so how would a sentence write? Because you're right, because it's something that Fran had mentioned and she mentioned multiple times. And so I think she said it while she was sitting as a commissioner during a commission meeting, is that when we're thinking about the public health system investments go beyond what MDH has control over and funnels through the Public Health Services Administration or Behavioral Health Administration, but that it does also include those contributions. And I think she's actually said it in a much more important way, which is how those funds are spent absolutely impacts the public health system. The opportunity for public health advancement or missed opportunities for public health advancement. And so so now that I'm recalling what Fran has said, I think it is really, we would be more than remiss. Perhaps we would be derelict in our duties if we did not include that in this recommendation language.
Thank you, Brooke. And I see Shane added a comment that could go under implementation. Yeah, but yeah, those are definitely two big key players for this recommendation. Thank you.
Any other comments, Chris? Anything from your perspective? Okay, Vanessa?
Just one note on the title. Would recommend revisiting the submission name. I think maybe like alignment or partnership or collaboration or facilitation, leveraging private health system resources, I think maybe reads a little bit differently than we're trying to convey.
Okay, thank you, Vanessa. Okay, are we ready for a vote on this one?
Just to clarify, are we adding in LHDs to the
yes, we are.
reviewing party?
Okay, let's shoot for a vote and see where we go.
This will advance to the June slate with the modifications discussed.
Okay, let's move to, I think GOC 052, was that the next one?
Yes.
Okay, continued support and enhancement for shared governance in Maryland Public Health. Comments? Yes, Mina?
Dr.
And maybe this is a question for Barbara, but I think in the work group discussions on this, or at least in discussions I had with Barbara on this, I thought there was going to be clarification in one of the strategies to improve the ability of local health officers to make agency decisions. I think that was part of the concerns raised through the assessment, was the layers of bureaucracy that are unnecessarily inserted into the system that affect the efficiency of the governmental public health system.
Yeah, so I think our work group didn't have an opportunity to revisit this language, but what you were just talking about, Mina, though, I do believe is in the spirit of what has been discussed in the work group since we've been meeting over a year. That definitely in the early days was coming up in every discussion that we had. So I think that would be consistent with those other discussions.
So then I would recommend then an amendment to this of adding in a fifth bullet, that is to improve the ability of local health officers to function as agency heads, so as to decrease governmental inefficiencies in the state's public health system.
Okay, now with that amendment, Dr. Rossman?
Yeah, it's really just a comment, but the third bullet, at least my interpretation of the core funding model is not a flat per capita model. So I just want to make that clear. So it already is a fairly complex model, and it's not flat per capita. So it's just a comment. So whoever wrote it may want to, I don't know what they want to change it to, but we don't have a flat per capita model.
Yeah, how about if it should read jurisdictions that are not accounted for in the current model?
Okay. So amended, Matt?
This is maybe more of a comment, but this feels more to me like just a statement of purpose, like a statement versus a recommendation. It's just an affirmation, and it might even be something we want to put in the body of the text versus it's not. It doesn't feel to me like it's a recommendation per se. We're not recommending anything. We're affirming through these.
Correct. And actually, this was maybe the last one that we had identified. And it was because we've been going all along talking about Maryland's still relatively unique shared governance model. And we have completely forgotten to express support for that, because an underlying assumption in all of our conversations have been that we think the current model, the shared governance, is by and large working well, with some adjustments. But considering a centralized model and a decentralized model, we believe that this shared governance model is still the way it's in Maryland's best interest to continue. And we were concerned that while we knew that was the framework and we were operating from that, people coming after us and people unfamiliar with it wouldn't know from reading this report whether such a fundamental organizational decision was one that we supported or not. I would agree. It would also make sense for the commission to have it in its general report, that it would not need to be a recommendation. From our work group, though, we did not want to leave it up to chance that a statement to this would make it in the final report if we didn't otherwise take steps to lift up this language for the commission to consider.
Thank you, Dr. Brookmeyer. Dr. Brewster?
I think Maura had her hand up first if she wants to go.
Oh, Maura. Sorry, Dr. Russman.
I'm good. Thanks.
Okay.
Great. Then may I recommend, I actually support this being a recommendation and not just an affirmation in the text. And that's primarily because it says we support the following steps. If we just tweak that to say we recommend the following steps, then it might address Dr. Levy's concern about language of recommendation. So then the first part is more a prelude to the actual recommendation. But I think this whole thing should be in the recommendation, again, with the fifth bullet that I had proposed about local health officers functioning as agency heads. But changing the support the to we recommend the might be more consistent with our recommendation language.
Okay, so amended. Any other recommendations on this one? Shall we take it to vote? Okay, we'll advance to the June slate. Our next recommendation is, I think, 042, the Public Health Resource Team. Any comments on this recommendation?
Tosin here.
Yeah.
The question I have rather about this recommendation is more of funding. Is there funding attached to this? Is this going to be a new funding or existing funding? Because given the climate right now, 10 to 12, I think it's an awesome recommendation. just for the implementation of everything we've been working on. But just I have a question about the funding piece to this, and the number 10 to 12, if that can be clarified. Thanks.
Yes, thank you. We had some discussion in our work group about this. This is one of the recommendations from the assessment team, so we want to thank them for doing their work and combing through all of the information that they collected to try to make sense of it. And in trying to understand the origins of this recommendation, we can read through the assessment findings to see that how important it had been and how many recommendations from various sectors or from the information gathering had all pointed to that in order to make further advancements, that the hiring of additional staff. I can't speak to the number, how that was arrived at. I can tell you how we got it on this page, because that was the recommendation from the assessment team. And we did have discussion. We had discussion about, well, maybe we wouldn't put any number down. But we also wanted to honor the work that the assessment team had put into it and thought you need to start somewhere. And 10 to 12 is not unreasonable when we're looking at the breadth and the depth of the work that's ahead of us. You're going through this, well, you're already probably thinking about, the report in June, but when you look at all of this, it is going to take, if we're serious about it. So that's it. So with all these, so we had the discussion, well, you know what, we'll just add it to already busy people and it'll be, a side thing. But if we're really serious about this work of the commission being implemented, you need to make the commitment of additional staff to do it. So I think that's where, we ask the commission and the commission's report, the recipients of this report. And if they're serious about this, still serious about this, you need to make the investment. You need to make the investment in the staff to help make this happen.
Thank you, Barbara. And then Amelia put in the comments that the 10 to 12 number came straight from the interviewees as part of the assessment. Any other comments? Okay, shall we take this one to vote?
This will advance to the June slate.
Okay, this is now, next one I think is 043, Maryland Department of Health, Public Health Grand Rounds Series. Any comments on this?
Don't see any hands raised.
Okay, let's take it to vote then.
Sorry, I have one quick comment.
Yeah.
This one and the next one sort of seem to me to be like a public health, and maybe I'm reading it wrong, but like almost like an enhanced public health visibility, like under the same plan. Like the recommendation would be more improve horizontal communication through the Maryland Health Department, and then the action items would be this one and then the next one underneath it. I'm just throwing that out as a consideration. That way it seems like the recommendation is enhance communication throughout the organization around public health and cross collaboration. And then the way you do that is through ran rounds and whatever the other, I can't remember the other one.
Listserv.
The listserv, yeah.
So this is Barbara. Yes, so I can appreciate your comment, and again, our assessment team colleagues and Dr. Aria put something in the chat there. One, we wanted to make sure that while there is an overarching umbrella, it's about communications, they are discrete activities. And if one was not going to proceed to the June meeting, we wanted to make sure that the other one was. So it's how much do you lump and how much do you keep as discrete? But I can see when it comes to the June report, you might want to do some more lumping, but we didn't want to lose the specific assessment team recommendations for these two separate ones.
Yeah, I would, at this point, Matt, sort of keep them as two separate recommendations. I think you have a point to make. The grouping may occur for the June slate meeting, or actually may even occur for the final report, right, with editing of all this, right? What we're doing is let's keep them distinct right now just to make sure that we sort of believe in the spirit of them. But good points. Any other comments on 043?
Hi, I assume that first E is a typo.
It is.
Okay. Thank
Yeah,
you.
and we'll work through all the typos. I know there's a lot of moving targets, as you all understand, as we're putting things together, but thank you for that. Let's move ahead on the vote for 043.
Okay. This will advance to the slate.
Okay, thank you. Now let's move to 044, which is listserv for local health departments. Any comments? So.
Hi, sorry. This one, great for it to be a recommendation. We do this now. This seems like a really low lift. I'm not sure who proposed this, but if they want to get in touch with me, this might be one we could just take care of.
Great, Barbara.
Yeah, this is also one that came from the assessment team.
Okay,
and
Amelia.
We actually, my initial proposal to the work group was was something along the lines of what Vanessa had said. But then in reviewing more of the assessment team findings and the context in which it sits in, and that this might be more about communication of local health department to local health department, that we then voted to submit this as its discrete recommendation. And thank you, Dr. Aria, in the chat, that you heard that people needed one. So the assessment team was just letting people know it can be used. And if it exists, then that would be one of those early wins, but it sounds like at least from some number of contributors, because I think that was the other thing that we had the discussion in the work group. Well, was this from one person? But it sounded like it was from multiple. So it's indicating somewhere along the line. But again, I believe it was it's local health department to local health department awareness and communication beyond the health officers having our regular forum for that.
Okay, Mina.
Could I recommend this be changed to promote utilization of LHD listservs to facilitate communication between them and to share resources and announcements? I think there is an opportunity to improve both awareness of what's existing, but also there may be some utility in additional listservs for specific groups of staff across LHDs.
Okay, so amended. Any other comments on this one? If there are none, let's move to vote on 044.
This will advance to the June slate.
Great, thank you. Our next one, remind me what number we're actually, I know we jumped around here a little bit.
We went to 026 academic health departments.
Great, 026 academic development and support of academic health department partnerships. Any comments on this one? Okay, let's take this one to vote, 026.
Just waiting on one more. Okay, there we go. This will advance to the June slate.
Great, we'll move to 061. Which is establishing a statewide racial equity impact assessment policy for the executive branch. Is this open to comments?
The comment I have is this one seems familiar. I don't know if it's the one next to it, just to clarify the difference. Yeah.
One is
There's
for
one.
the executive branch and one's for the General Assembly. So one is the legislation and then the other one is the executive branch regulations.
Okay, thanks.
Any other comments on this one, on 061, which is specific for the executive branch? And again, grouping wise, we can handle that in editing later, but we're going to handle them as two separate recommendations at this point. If there are no comments, let's move to vote on 061.
Just waiting for a couple more votes. This will advance to the June slate.
Great. And let's bring up, I think, what is our last one for this grouping. It's GOC 062, which is establishing the racial equity impact assessment policy for the General Assembly. Any comments on this?
I don't see any.
Okay, let's move to vote on 062.
Just one more vote. Are one of the commissioners having issues. I only have 8 votes, but we've been in 9.
Anyone having problems voting?
Okay, there we go. All right.
Okay, thank you.
This will advance to the June slate.
Okay. We'll go to our next grouping shortly. I do want to sort of acknowledge that we are at a 10-minute mark right now, and we will continue until the 3 o'clock hour. And if there's a motion at that point to continue discussion, we'll take that motion at that point. So let's get as far as we possibly can right now. So Shane, what's our next grouping?
We have a couple submissions related to workforce. However, they came from the local health department, or I apologize, the assessment team findings. So, here we go.
I think these might have come from workforce work group.
Oh, were they? I apologize. I might have misunderstood that. Okay.
Okay, let's go.
We'll let the work group speak for themselves then. So the first one is WKF 053, appoint a statewide volunteer coordinator for emergency preparedness. And the recommendation is to hire an individual to serve as a statewide volunteer coordinator for emergency preparedness. WKF 054 is to appoint a statewide chief nursing officer with recommendation language of the same. And those were the only 2 workforce related submissions we had.
Great. There's a question that came up just sort of from Barbara. Did we vote on GOC 57 LHD accreditation? I didn't see that on our list. 057, Shane?
We did not, but I don't. I might have missed it on my.
Okay, I don't see it on the prep sheet. Okay, if we can track that down, if possible. If not, let's continue with any discussion on 053, which is statewide volunteer coordinator for emergency preparedness. Any comments, Vanessa?
Hey, y'all. On this one, love this idea. So supportive of MRC and have seen so many other states like Pennsylvania and Virginia run these fabulous coordinated systems. Just wanted to flag big picture. All of our preparedness folks are federally funded. So we don't have any state funded preparedness positions in the agency. So this is a great idea, but just wanted to put out that big picture for your consideration.
Yeah, understanding that would be an obstacle down the line. Yeah, understood. Thank you. Any other comments? There being none, let's move 053 up for a vote.
Just waiting for one more. This one will advance to the June slate as well.
Okay. Let's jump to 054, which is appointing a statewide chief nursing officer. Any comments?
I don't see any.
Okay.
I have a comment. Sorry.
Yeah.
Is there any educational requirement for the statewide chief nursing officer? Thanks. Or would that follow suit with the,
I think it would be based on what
based on, yeah.
classification is selected in the state personnel system.
Okay, thanks. Got it.
I would make a recommendation to amend this to include a focus on expanding the nursing workforce. Like, I mean, it's just such a huge crisis.
Okay, so
you mean within the public health system or just
No,
generally across the
nursing, like if you're going to create a statewide chief nursing officer that beyond just public, like it is a public health,
right.
The shortage is having an impact on public health, but it's a big problem. It's making our delivery system completely unaffordable.
Mm-hmm.
The supply and demand mismatch is making it, we can't afford for people to ever retire, like it,
right,
and get old.
Yeah, that's a great idea. I would recommend it as a phrase in the last sentence. Such leadership could coordinate nursing related activities, et cetera. Look at statewide nursing workforce strategies or spearhead, something like that.
Something explicit around expanding the workforce. It's growing the number of nurses. We have to address the supply and demand mismatch.
And I would also include, to partner with, if possible, I know there's a state workforce commission headed by University of Maryland for nursing. So, partnership with such, I think would be great.
okay, as amended. Any other comments on this one? Okay, let's bring it up for vote.
All right, this will go to the June slate as well. And circling back, I apologize. It looks like GOC 052 was included in the packet, but we overlooked adding it to the prep sheet, which is how I missed it. So that's on me. But this is related to local health department accreditation, with the recommendation language that MDH should facilitate the accreditation or pathways recognition status of interested local health departments by the Public Health Accreditation Board or similar accreditation and pay the annual fees.
Okay, this is up for discussion. Any comments at all? Okay, let's bring it up for a vote then.
Missing 2 votes. One vote. Camille?
I just had a question. I know everyone's voting, but I'm wondering what the benefit of accreditation is at the local level. I mean, there was once a time where federal accreditation was, or state accreditation was relevant for like federal funding dollars. That may not be the case anymore, but like, what is the benefit beyond the the recognition?
So this is Barbara. I could address that. There had never been, at least for local health department accreditation, there had never been dollars attached. At one point, it had been thought that perhaps as an incentive for local health departments to be accredited, that federal funding sources or others might give priority or preference to local health departments that have achieved accredited status. That is not the case. However, I would say that locally, there is recognition that and prestige when there's an outside entity that has established indicators of a high functioning local health department or state health department and has evaluated the local health department's conformity to those. And that locally, it has been a source of pride among staff, which is quite important, as well as for the also quite important is folks on the outside, whether there are partners or elected officials, that I personally was surprised at how important it was to them. I did not expect that our achieving accredited status back in 2014 would have had that impact, but it did. So I think there are some intangible benefits that should be recognized. And also when we talk about transparency and accountability, that the FAB standards help to reinforce that and help to make sure that we are continuing to operate in a way that provides some accountability to the public that their local health department is in fact meeting the standards.
I know we're past time, Boris. I don't know if I can still have the floor with a couple more questions.
Yeah, let's complete this discussion. Then I'll put up a vote as to whether we have to adjourn our meeting. I know we had a 3 o'clock finish, or whether we extend it to complete more business. So Camille, continue with your discussion on this once we can complete this.
Thank you. I know voting had already started, and then my mind just clicked into this. What is the cost? Do you know, Barbara, what the cost is for accreditation?
I could tell you in a little bit. They have not. Last week they shared in a meeting that they haven't raised their fees in 15 years, and I will look to see. It might be $6,000 or $8,000 a year. It does vary depending upon the size of the organization.
Yeah. And my final question is, and maybe Vanessa, you know the answer to this. I don't. When we got state accreditation from FAB, did that include an analysis or an evaluation of our local partners?
No.
Vanessa?
So there's requirements in the standards and measures that talk about working across agencies, working across partnerships, and there's specific plans that FAB, Public Health Accreditation Board, looks at where they have an expectation of meeting certain recommendations. MDH as a state was actually accredited and reaccredited under the 1.5 version and will now be rolling on to the next version. So lots of complexities and changes going forward. And I think what Barbara said really echoes some of my thoughts on this recommendation, which unfortunately are not super positive, is what happens to our national partners and our associations over the next 6 to 12 months, what happens to public health accreditation and the Public Health Accreditation Board. So hard to take a position.
Yeah, that's helpful. Thank you. Appreciate everyone's feedback.
And so for the size health department that the Frederick County Health Department is, it's $8,400 a year.
Thanks for looking, Barbara.
Mm-hmm.
Okay, any other comments as we're in the midst of this voting? Thanks, Camille, for those good questions. Okay, let's continue the voting on 057.
This will advance to the June slate, and of course, as we've noted, can be commented on during the open comment period and further refinements. So, Camille, your questions I think were relevant. Thank you.
Okay, let's just sort of the point that we're at right now. I think by my count, Shane, we have 3 from communication, public engagement, and on the prep sheet, and 4 that are cross-cutting. And the question to the group is, Nicole, you just wrote in, you can't stay past 3:10, and we're approaching that hour quickly. Are we going to lose quorum with Nicole's departure? And the next question is, are there anybody stay on until the 3:30 hour? And if not, we may have to, I don't know, it'll mess us up a little bit for the June meeting, but we may have to complete the slate. I'm not sure how we're going to get in another meeting. So Matt's going to have to jump off to get on the plane, and Camille can stay on, but I think we're going to start losing quorum, Shane.
By my count, we would be pretty close. I think in that vein, maybe it would be more instructive for us, or constructive rather, for us to look at adding some time to the June 5th meeting, or sometime in between.
Okay. So, yeah.
I don't know if I don't know if I would make or break this. I really do need to go, but if me staying on till 3:30 helps us keep quorum, I can do
No,
that.
I think we're going to lose others. I think we're losing Matt. He has to get up on the plane. So I think at least it's you. And where are we at in terms of quorum right now, Shane? Are we still at 10?
By last count, I had 10. So if 2 dropped off, that
we're still
puts us right at quorum. But if anybody else left, we would have to monitor.
I'd like somebody to propose a motion to keep the meeting going until 3:30, provided we have quorum.
I move Tosin.
Okay.
Second.
Everybody who says aye?
Aye.
Aye.
Aye. Any nays? Okay. Any abstentions? Okay. Matt will stay on as long as he can. Okay. Appreciate that, Matt. So we'll continue on. Let's do our next grouping then, Shane.
Okay. We will go to the communications and public engagement work group, beginning with CPE 005, health communications tools modernization. The recommendation is that health departments should consider and use all available and relevant communication methods, tools, and partnerships to ensure they are meeting community needs and promoting modernization and expansion of health communication messages. The next is CPE 045, improving the visibility of public health. And I apologize, these are a little in collaboration with the academic partners, Maryland Department of Health could develop a Maryland Public Health Issue of the Month series that engages the public and policymakers in plain language and multiple formats, such as videos and infographics on a particular topic. The series can explain what solutions are being used today and what the needs are to strengthen Maryland's capacity to address the issue. Wide dissemination to the public and policymakers could enhance the trust and visibility of the valuable work going on at the local level, and clarify the scientific evidence around timely topic or call attention to emerging issue or outbreak. CPE 045, or no, sorry. Myself in here. That's funny. Health communications and materials dissemination support, CPE 020, to promote the dissemination of health communications material to the public, state, and local health departments, should prioritize existing funding or, if possible, allocate additional funding to enhance communication capacities foster engagement with the public, and reduce rumors and misinformation. I believe that is all we have from the communications and public engagement work group, unless I've missed something.
Great. That's the three that were on the prep sheet. So let's go to 005, the first one presented, which is health communication tools modernization. Any comments on that? There being none, let's move to vote.
This will advance to the slate.
Okay, thank you all for sticking through this. Let's do the next vote on 045, improving the visibility of public health. Any comments?
Yes, I just recommend that we change the word could to the word should, just to align with all of the other recommendations and language.
Thanks, Nicole. As amended. Any other comments? There being none, let's move to vote on 045.
This will advance to the June slate.
Okay, and let's move to 020, the health communications materials dissemination support. Any comments on this one? There being none, let's move to vote. Oh, Vanessa, you have one? Yep. Go on, Vanessa.
Continuing to struggle with the button. Curious what the barriers are at the local level. I know at the state level, often pulling all these communication levers is challenging based on purchasing and procurement requirements. Don't know if there's a place to include that or recommend improving that, but just noting, curious what the challenge is at the local level.
Local perspective, Mina, anything from you or?
I think funding is probably our biggest barrier, but it's also leadership prioritizing communications functions.
I second Mina's thoughts on that. Yeah.
Any other questions, clarifications? There being none, let's move to vote. Zero.
This will advance to the June slate.
Okay, thank you. That's our last of that group. And then we have a grouping of cross-cutting. So Shane, you want to go through that group?
Yes. Okay.
And I think these would be our last four for the day. So we're almost there, folks.
So CCR 063, Population Health Improvement Fund. Recommendation is to ensure that Population Health Improvement Fund established by the General Assembly to support the all-payer health equity approaches and development, or AHEAD model, has a governance structure that reflects state and local public health social services, health system, business, and philanthropy sectors, and is representative, nimble, and independent. These attributes are important to secure the trust and confidence of the people of Maryland, its elected officials, health system, business, and philanthropic leaders. The Commission supports orienting the Population Health Improvement Fund to operate adjacent to care delivery system and in alignment with the vision and goals of the AHEAD Model Agreement, the State Health Improvement Plan, and the Emerging State Health Equity Plan. Next is CCR 064, Governmental Public Health Foundational Services and Behavioral Health Services. Recommendation is to create an efficient and cost-effective strategy to coordinate governmental public health foundational services and behavioral health services to minimize inefficiencies and to maximize timely and effective services for community populations. While the Maryland Department of Health houses both Behavioral Health Administration and Public Health Services Administration, challenges and authorities at the local level complicate case and community health management for behavioral health services. Next is CCR 065, Expanding Primary Care Services. Language reads, provide resources to and acknowledge the support of the expanding primary care services, including behavioral health services, provided by Maryland's local health departments. These services contribute to Maryland's innovation in health improvement and health care and are essential components of the continuum of care. While Maryland's healthcare reform initiatives, including hospital and primary care, provide important investments in population health and disease prevention and health promotion, and county reviews provide geographically based specific needs assessments. Not all populations in the state have the same opportunity for these services. These services are in addition to Maryland's governmental public health service role in ensuring access and linkage to care, clinical care. And I believe that is all. Oh, no, I apologize. There's one more. Let me see. Sarah, do you remember where that, in which file that CCR 055 was? Oh, wait. Here it is. Apologies. CCR 055, placing public health navigators in the community, create non-clinical friendly resource hubs within brick and mortar public shopping districts where residents can learn about and access assistance with a variety of health-related needs. These spaces would be serviced by community health workers and have state-of-the-art technology and be able to provide information on a variety of topics like home health for elderly populations, when to consider mental health assessments and how to access them if needed, the benefits of screening for medical and dental health, and many other public health oriented activities.
Great, so that's our grouping of 4. So in that order, let's go to whichever one is the easiest one to bring up. You have 063? Or whichever one you have, Shane, just for an element of time, whichever order.
Yeah. Population Health Improvement Fund is up. So 0.
Population Health Improvement Fund is 063. Any discussion on this one? Yes, Vanessa.
Not so much on the content, just the wording on this. Recommend changing to Maryland's payment model or something to that effect. We don't know exactly what's going to happen with AHEAD as currently named. So just recommend referencing as Maryland's payment model.
Okay, thank you. As amended. Matt just announced he's jumping off. Thank you, Matt, for being part of this. Okay, Vanessa, thank you. Anybody else recommendations on this one? Okay. If there are none, let's take it to a vote.
Just waiting for one more vote. Okay. This will advance to the June slate.
Okay, thank you all. Let's move to the next one. I think it was 064, Governmental Public Health Foundational Services and Behavioral Health Services. Any comments?
Yes, this is Nilesh. Can someone from the work group just? I've read this a couple of times, and I'm not clear what we're trying to accomplish here. So, want somebody from the work group to talk about that.
Great, and this may be from the cross-cutting. So, Amelia, are you still on?
Yes, I am, but I'll let Dushanka handle this.
Okay, thank you.
Thank you, Amelia. This particular recommendation really addresses the statute, which asks to take a look at the role of behavioral health and public health. And given that particular connection, this is a recommendation to take a look at the actual implementation and oversight for behavioral health within public health as delivered at the local health level as well as at the state level.
So is this for a study group or is this like for a change strategy? I mean, it says create a strategy, but the strategy doesn't appear to be like very clear. So as to, are we talking about merging local behavioral health agencies with health departments if they're not already in that organizational setup?
It's more the coordination. It doesn't address the merging at all. It's taking a look at the two entities and seeing how they fit together and to what degree the services that are expanding in the behavioral health area delivered by local health departments concurrent with other services. Are there ways in which to look at the efficiencies and administrative aspects of that would look at that integration or collaboration or coordination of care?
Chris, was that you with some questions or not?
Yeah, I mean, I'm generally very supportive of, of just a strategic look at really all of the public health services to figure out, how do we get more bang for the buck? I think that's what this reads.
Okay, other questions, comments?
I'm not sure I see the other pieces of the beyond the recommendation language, the assessment findings and how it would improve. Just if there's more information on that. But this is a wonderful recommendation. Just wanted to note. Thanks.
Yeah, similar to other recommendations, we continue to add and refine these, but in the spirit of honoring the timeline and getting it in front of folks, we did not want to artificially limit that.
Got it. Thanks.
Okay, any other comments? There being none, let's vote on.
And I'll note that Dr. Levy just noted he had to jump off.
Mm-hmm.
This one will advance to the June slate.
Okay. Let's go to 066 or 65, which is expanding primary care services. Any comments?
Just I think we should, wherever the language, when it pops up, it says including behavioral health services. I think we should say as well as behavioral health services. So the expanding primary care and behavioral health services.
Nilesh?
Yeah, this one I have some significant concerns with. Local health departments are free to engage in in primary care services or behavioral health services. But I think one of the distinctions that we need to remember is what are the core public health services that need to be delivered that can't be delivered elsewhere? I mean, I come from more than a decade in primary care delivering integrated primary care and behavioral health services. And I can tell you from that side of the fence, right, there are things that we could not do that public health did. And in that same way, I think that if we start diluting our function of what public health is by really promoting primary care delivery, and there's an entire mechanism to do that, and promoting behavioral health treatment options, there's an entire mechanism to do that, right? We weaken and dilute what public health is. And I think that's a bad step for us. There's, like I said, there's freedom to do that. But to promote and push that from a statewide perspective, I think is counterproductive.
I'll just Nilesh, I'll take the other side on that one just because I like us echoing what the rate setter is trying to do and others is there. I don't see the downside on this. The impact, and as your work in primary care, you know how important it is. So I mean, like, what is you think that we're going to dilute our message by saying, as public health leaders, we think primary care is super important and should be emphasized when we know that it is underfunded relative to other things? To me, this one is. I mean, unless I'm reading this wrong.
This isn't. I don't read this as being about the importance of primary care. This, as I read it, says that local health departments will start delivering primary care, right? So just reading the first sentence, provide resources to and acknowledge the support of expanding primary care services, including behavioral health services provided by Maryland's local health departments. I'll promote primary care any day of the week. I mean, I live that. But the service delivery is hard. I can tell you that too, right? And if we're starting to promote LHDs to either get into this space or expand it, that starts taking their time and energy away from other services that nobody else will deliver. And if we're not doing the one thing that only we can do, then we're diluting our function.
Okay, Maura, you have a comment?
Yeah. From my perspective, yes, we need more primary care in Maryland. We need more primary care in the United States. There's no doubt that I'm supportive of primary care. Maryland, historically, because of the way we're designed, does not have a our public health system is not designed currently to provide primary care. So if we want to become more like California, where there are free clinics, public clinics, then we have to redesign, in my opinion, our whole system and how we fund healthcare in the state of Maryland. So I for different reasons, I would be very cautious about this particular recommendation, understanding that I think there's significant ramifications for it, and funding. If public health right now, we don't think we have enough funding with EMRs and blah, 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 we definitely do not have the capacity and the infrastructure to implement standard of care as in a primary care setting. And I think Nilesh touched on that. So pro primary care, we need more of it, but we should know what we're getting into here.
We're almost at time. I'm going to allow Dushanka from the assessment team to comment, and then we'll take it up.
Okay.
Dushanka.
Thank you very much. The assessment findings show that the local health departments are providing primary care, but as well as behavioral health services. The issue that is resonating with that finding is that those services, like Nilesh said, should be covered within enhanced primary care, but they are not, because they are needed in those areas and they're not being covered. So taking a look and seeing the continuum of care that public health sets the foundation for, and its referral to access and linkage with clinical care would be the ideal way. But at this point, the growth of primary care is occurring, and maybe it's more of a focus at taking a look at that piece of the care being provided and looking at whatever would be the integration or the collaboration between primary care and public health.
Yeah, very briefly, I just wanted to add to what Dushanka said. School-based wellness centers are, providing primary care. So, just keeping that in mind, I think it's a matter of capacity now. We might want to say maybe like enhancing or, encouraging more local departments to have school-based wellness programs. Speaking to Nilesh's point, but what is, like, is it what we want all LHDs to do? Can we afford that? Yeah, capacity issue, but yeah, just wanted to note that. Thanks.
Nilesh?
Yeah, Tosin, just responding to something you said around school-based health centers. One of the things that we're pushing is actually greater FQHC involvement, because the financial stability of school-based health centers in Maryland is very different from the rest of the country, precisely because we don't use FQHCs and their rate enhancements that they're able to get from Medicaid. And so I don't want us to walk down a path that's actually less financially viable, where there are players that could execute in that space. So I just want to bring that up since you brought up the school-based health center.
Yeah, thanks.
Great, folks. We are at time, so either we're going to have to do a motion of extending, or we divert this to the next meeting. Not sure how people are with time and whether we're still at quorum or not.
We still have a quorum, but to Dr. Rossman's point, I think if we could just vote on this one. What I'm hearing is we need to soften the language, and instead of including behavioral health, it's in addition to behavioral health. Those were the two things that I heard.
Okay, let's complete it and place a vote on this.
All right, the polls should be open. Okay. This will be recommitted to the work group, which is support staff in this case, since it's cross-cutting, and we will bring a revised version to the June 5th meeting.
Great. Okay, and we have one other one that we'll be losing quorum at this point, so we'll have to just have one other vote on the placing public health navigators in the community at the next meeting. Correct, Shane?
I think we might have had a couple other cross-cutting recommendations, but we'll bring those on the June 5th as well.
Okay, great. Thank you all for allowing the extension. We got a lot of work done, and it's always difficult in the chair's prerogative to to kind of allow or stop conversation. I am so enthralled with you as commissioners because we really had some really good. Some passed through, and others, obviously, there was a lot of good discussion. So thank you all for being part of this process. Just a reminder that our next meeting date is June 5th. This is the meeting. We'll try to get there in person if you possibly can at Prince George's County. Otherwise, it will be a hybrid meeting, and this is really the discussion of the slate. I'll ask now for a motion to adjourn this meeting.
So moved.
A second. Great. Everybody for adjourning today?
Aye.
Aye. Anyone against? Anyone abstaining? Great job, gang. Really, really good meeting today.
Thanks
I'm
to the
tired.
chairs. Nice work.
Hey, Chris, thank you for being here, man. Good comments. Okay. Kudos to everybody.
Good job. Thank you. All right, bye.